Slide, please. Yeah, so the pathophysiology of this is that there is an inflammation with smooth muscle cell apoptosis and also an extracellular matrix degeneration in the vessel wall of the aorta. And we speak about an aneurysm when there's a dilation of 50% or more of the original diameter of the aorta. The risks are in high association with the common risk factors for arteriosclerosis, but one to especially point out is smoking. And paradoxically, obesity is actually protective to have a lower risk for aortic aneurysms. There are also, as you probably know from your genetics classes, many genetic disorders that lead to a predispositioning to the development of aortic aneurysm. Here we have the Marfan Syndrome, the Loeys syndrome, and Pectoris syndrome as the most prominent of those that probably all of you have heard already about. And what is interesting there is because there's this predisposition, the threshold to initiate the treatment of the aortic aneurysm is lower. So the treatment is initiated faster than in a normal, otherwise healthy patient. And the tricky thing about aortic aneurysm is that there are actually not really symptoms. And if there are symptoms, it's already too late, because if there's pain, there's a rupture of the aneurysm. And that's a very, very big emergency. Typically, it is, because there are no symptoms, typically found as a random finding during palpation of the abdomen, or maybe an MRI of the abdomen, as a pulsatile and non-tender mass in palpation. Yeah, so diagnosis is, as I said, visually, or with palpation, but visually we confirm it then, and with abdominal ultrasound we then monitor the size. And for more precise visualization and for the planning of the operation, there's usually CT with contrast used or an MRI. The treatment is quite straightforward. There's only an invasive treatment, which is usually initiated in asymptomatic patients when the aneurysm is bigger than 5.5 centimeters. And we use for that an endovascular stent graft, which you can see in the picture on the upper right corner. Now we come to a bigger group of diseases which are associated to atherosclerosis. And here we have a nice picture that visualizes how arterial plaque develops. So in the beginning, we usually have excess low density lipoprotein in the bloodstream, which then penetrates through the endothelial surface of the vessel, and it deposits itself in the intima and causes an inflammation there, which then in turn attracts macrophages, which then ingest these fats. And those macrophages that ingested these fats are then called foamy macrophages, and they accumulate there and form the so-called fatty streak. And then the lesion grows because there's more inflammation, there's more fats coming in, more macrophages then ingesting that those fats, and the lesion continues to grow. And then we have at some point an atheroma. But after that, there's a next step where a fibrous cap is developing. And this develops because the smooth muscle cells start to, in the intima, start to secrete collagen. And then a fibrous capsule is formed. And then this structure we call fibroatheroma. But then there's even a more, let's say, dangerous and complicated structure can form, which forms when there's a continuous inflammatory response. And then because of that, the macrophages started to secrete metalloproteinases, which in turn destruct again the fibrous cap, which leads then to lesions, and then thrombosis can form, and even embolization, and many of our pathologies can be very severe then. Next slide, yes. And then we have the general risk factors, which are very common. It's high, low density lipoprotein levels in the blood. It's smoking, it's hypertension, it's diabetes mellitus. It's those typical risk factors for cardiac diseases. Yeah, now we come to the diseases that are associated with atherosclerosis, and you have to imagine that there are not only a few. Atherosclerosis can be everywhere in all arteries of the body. But here we focus on three very typical diseases. One is the carotid artery disease, which is in the carotid artery. Then there's peripheral artery disease, which is in the peripheral arteries, most common in the femoral and popliteal artery. And there's coronary artery disease. So first, I will talk about carotid artery disease. There are atherosclerotic changes in the internal carotid artery near the bifurcation of the common carotid artery is present. They can either partially occlude, completely occlude the artery, and even some embolization can occur, which then could lead to stroke in the brain because smaller vessels more upstream from that vessel are occluded. And this is also quite tricky because there are not always symptoms in this disease, because as you know from anatomy, there are two carotid arteries already in our body. So the blood flow can be compensated, and also there are the vertebral arteries which supply the blood, the brain with blood. So this can be just compensated and you don't really see any symptoms. Yeah, and as we don't really see symptoms necessarily all the time, it's often that there are also just random findings of these diseases when, for example, an MRI of the neck is performed. And if we see symptoms, we see ischemic symptoms on the ipsilateral side, so the same side. For example, in the eye, blindness, or if there are hemispheric symptoms, we have hemiparesis or hemisensory loss. And also a thing that can be heard sometimes, but not all the time, is a carotid bruit. So on auscultation of the carotid artery, we can hear a bruit, something that doesn't sound smooth. It's like the twirl of a water which you let out of the bathtub. You can imagine it somehow like this. But unfortunately, it's not always there. But if we hear it, it's quite a good predictor that there might be a carotid artery disease underlying there, but it's also not 100%. Yeah, treatment, first of all, more conservative is always risk factor modification. So stop smoking, try to reduce your weight, control the diabetes. There's also medical treatment where we use antithrombotic agents and statins. And the surgical treatments, which is carotid and arterectomy, which is a surgical excision of the arteriosclerotic plaque out of the vessel wall of the carotid artery. And then, of course, also carotid stenting. And now to coronary artery disease. There, an inadequate oxygen supply to the myocardium causes the problems. And the reasons for that is that the coronary arteries are again obstructed by atherosclerosis. This can be again complete or partial. The presentation can be roughly divided into three big groups where we have stable angina, which is a predictable pain in the chest on exertion, which is caused by the narrowing due to the plaque of the artery. Then we have unstable angina pectoris, where it's an unpredictable pain in the chest. And this is caused by narrowing due to a thrombus. So it's an instant occlusion. It's not this partially progressing as in stable angina, where the atherosclerosis sclerotic plaque is slowly more occluding the artery. And then there's myocardial infarction, which is the death of the myocardium from hypoxia, resulting in chest pain. And there we can see the acute coronary syndrome with or without ST segment elevation on the ECG, which is shown here. Next slide, please. Yes, here we can see ST depression on the left side, which is a typical sign also of hypoxia of the myocardium. And on the right side, we can see this typical ST elevation of the myocardial infarction. Yeah, and now about the treatment. For stable angina, we can, of course, treat it also medically. There we use nitrates, beta blocker, calcium channel blockers, and antiplatelet drugs. For the acute coronary syndrome, we have the nice mnemonic MONA that probably many of you heard who already had cardiology. And this reminds us of the use of morphine, oxygen, nitrates, and aspirin in acute cases. And if it is not possible to perform a percutaneous coronary intervention in the next 90 minutes, we also should perform fibrinolysis with alteplase. And of course, also just coronary percutaneous coronary intervention is then also used for stable angina to relieve the symptoms from the patient. Now about peripheral artery disease. This is just a stenosis or occlusion of the aorta or the peripheral artery, so it can be theoretically anywhere. The main causes are atherosclerosis, and this is the leading cause for all patients over 40-year-olds. Also, embolism and vasculitis can cause this. As I mentioned already before, it is most often seen in the femoral or popliteal artery, and it causes an hypoxia in the tissues that are typically supplied then by this artery. Yeah, and as we have this hypoxia in the tissue that is supplied by the artery, we have these intermittent claudications. This is pain, ache, or fatigue of the muscles after exertion. And it relieves after rest. So when you move, when your muscles move, they need more oxygen. But as the blood supply is reduced due to the narrowing of the arteries, there's just not enough oxygen and there's hypoxia in the muscles. And this is bad, but also nice for us because we can already think about, okay, which artery is affected. For example, when there's calf pain, the femoral or popliteal artery is most likely affected. Another sign is a decreased pulse behind the affected sites because, again, less blood can be pushed through, less pressure can be pushed through, and we have a weaker pulse. And also, again, we can hear those broods over the narrow part of the artery. Treatment, very typical, again, risk factors, reduce them, live a more healthy life. Then antiplatelet therapy with aspirin clopidogrel, cholesterol reducing therapy with statins. And then in the end, we have the percutaneous transluminal angioplasty, where we can then introduce a stent into the artery to open the lumen again.
Hi, so this is the scenario. We are in the Cath Lab, which you can see in the picture. And this is like a hybrid room somewhere similar to an OR, but it has an angiography machine. And here we place the catheter into the right or left coronary artery, and then, or maybe like a bypass graft, and under fluoroscopic guidance, so with contrast medium, we inject the contrast medium and opacify the lumen so that we can see where the arteries are and their status. And we take a short video of that with like 15 frames per second and several projections to assess, is the bypass graft still potent? Are there any congenital abnormalities in the coronary circulation? And most importantly, stenosis. So here we see a picture. I mean, I hope you have already some kind of knowledge about this. So most frequently we visually assess the stenosis. Don't you worry, in this picture there is none. And because we compare wherever we think there's a stenosis to a reference segment that we, for us, have defined as normal. And if there's a 50% reduction in diameter, we can already say that this is the minimal lesion severity required to interfere with myocardial perfusion should there be maximum exertion. And here in this screenshot of sort of a video taken during angiography, we have the area caudal view, and we see the distal left main stem at the top with the left anterior descending artery and the circumflex artery with its branches very nicely visible. then, so of course, in an optimum case scenario, we would hope to sort of have the stenosis somewhere, some percentage of stenosis, and we just try to fumble about with our guiding wire and sort of poke through this lesion and then be able to put a stent in. But unfortunately, that's not always the case, and we need to dilate this lesion to prepare for a stent. That we can do with several different kinds of balloons, which is called balloon angioplasty. And for that, we can always use the standard balloon. The advantage is that it's very, very slim and fits through very tiny vessel parts. And then we inflate it and sort of stretch the lesion. But, and it can sometimes happen, like you see in the smaller picture B, that it doesn't inflate to the same diameter in the whole part of the balloon. And to avoid that and unequal standing during the lesion, we can use non-compliant balloons that ensure there's proper dilation along the whole length of the balloon. But they take up more space in the vessel loom because they are thicker. And so sometimes we need to use one first and then the other. To further sort of help with the dilation, we can also use cutting or scoring balloons. Both of these have sort of knife-like bits attached either lengthwise or helically to the stent, as you can see in the picture, and they cut into the vessel wall to help with dilation. And then, especially in the scoring balloon, where you can see the helical wires around, they also help avoid that the stent during, the balloon during inflation sort of slips more distally into the vessel, where it would be easier for the balloon to inflate because there's no plug in the vessel wall, because it has these, so it helps with the, yeah. What we can also do, and this is where we realize that interventional cardiologists are basically just plumbers, is that when we can't just push our guiding wire through the stenosis, we need to use rotational atherectomy. And there we have a small burr that rotates really fast. And with that, we sort of ablate the plaque that is causing the stenosis and sort of drill a hole through the artery to free it again and then be able to dilate and ultimately insert a stent. So here we see how a stent is inserted. So we have already some dissections where we pre-dilated in this scenario, but also sometimes we don't actually pre-dilate. And that's actually like a really nice scenario because the procedure time is shorter, we have less exposure to radiation and contrast media, and also the cost is significantly lower because, I mean, have you seen these balloons? The technology is insane and they're also insanely expensive. And especially the little burr is expensive because it actually has a little diamond head that acts as the drill bit, so to say. So if we can avoid pre-dilatation, how do we say avoid, but if we can go without pre-dilatation, then we would, of course, prefer direct stenting. And to decide whether we want to direct stent or use some angioplastic approaches beforehand, we would use intravascular ultrasound or optical coherence tomography. And that I'm going to explain to you because I guess you haven't heard. So in intravascular ultrasound, there's sort of a catheter with a mini ultrasound probe on the distal end, and you put that into the vessel, and you can look at a cross-section of the vessel and the atherosclerotic lesions. It's like a live picture. And here in these pictures, you can also see, so you have the vessel wall, this is the plug, here it is in green. Here we have the remaining lumen. And then this is what we see of the catheter with the ultrasound probe, so to say. And then optical coherence tomography is a different approach that uses light. So it also makes like an optical biopsy on the micron scale, and it's in real time. It's really nice. So here in this picture, we see there has already been a stent that's implanted. We see the little wires here, and they throw a shadow like in an ultrasound, and we can see the probe, and here neoarteriosclerosis in within the stent lumen, where we have sort of re-stenosis of the lumen. So, but what are stents even? Like, what do we know about stents? Let's start at the beginning. The first thing that was really developed was just a mechanical solution to maintain the lumen of the vessel, so a bare metal stent. And this already is still superior to just balloon dilatation or using the little drill head. So, but now it has been completely overhauled and is only really rarely used. For example, when it's not possible to give dual antiplatelet therapy long-term, or the patient requires non-cardiac surgery within the next 4 to 6 weeks, or there's currently active bleeding or a very high risk of bleeding within the next time. So, and then we have drug-eluting stents, and they are sort of the next step towards the perfect stent. Here they added to the metal platform a polymer coating. And in this polymer coating, we find an anti-restenotic drug that is either sirolimus or one of its derivatives. And this drug is released within the next 4 to 14 weeks from implantation. And this drug reduces when the neointimal hyperplasia in place of the stent, when the vessel wall heals after we have sort of ripped it a bit while we dilate it. One disadvantage is then that this polymer can be the cause of chronic inflammation at this site. Still, drug-eluting stents, as they're called, are superior to just bare metal stents. But they then provide a necessity that the patient needs to take dual antiplatelets for a significantly longer time than just with the bare metal stent. There's several generations now, so 2 generations of drug-eluting stents. The first one, only the sirolimus eluting one is still available. So they compared sirolimus and paclitaxel as 2 possible agents. I have listed the mechanisms of action for you here, but I doubt that's relevant for you now. And then they further developed a 2nd generation that's currently in use, and with sort of sirolimus derivatives. These stents have a thinner metal base. The polymer is more biocompatible and is a lesser cause of inflammation in the vessel wall. And you can compare the different substances they are coated with amongst each other, but generally that will go way too deep into the topic for now. So yeah, this is what's currently used, the 2nd generation drug-eluting stent. What can we further optimize about a stent? We have talked about how the polymer is a chronic stimulus for inflammation. So what if we removed it? So after the drug is released, the polymer sort of dissolves and it's gone, and then we have just the bare metal stent left. That would be a more ideal thing, right? We can reduce the time maybe to that we have to take the dual antiplatelet therapy, and the thrombotic risk is lower. And then we have a bare metal stent remaining. That would be nice. So at the moment, these are more or less comparable to the current drug-eluting stents. But another approach would be to even leave the polymer and coat the drug directly onto the stent. The drug is released, and again, the bare metal stent remains. But the advantage of these types of stents is sort of theoretical for now. And then what else can we modify? We have modified the drug, we have modified the polymer. There's only one thing left. We can modify the metal structure, and we can do that in 2 ways. So currently, we already have very thin stents with only 70 to 100 micrometers in diameter. but we are currently investigating further options where we either further decrease the stent diameter or increase the strut thickness. So the stent is made out of these little funky wires, and this is a strut, and this is the thickness. I hope that illustrated it well for you. And we are trying to sort of optimize these variables to eventually get to a stent that would be perfect for anyone, as always. But then here we go again. Invasive cardiology is very much linked to construction work, because why even leave the sort of metal thingy behind when the work of the stent is done, right? So it was thought about that you could just insert a scaffold that is also coated with a drug. The drug is released, and then after a year, because studies have proven that the stent complications mostly happen before 9 months after stent insertion. So then after a year, this scaffold that has been put up in the artery will dissolve. There have been different materials that these scaffolds have been made of. There's polylactic acid and magnesium alloy. These are the most prominent ones. The Absorb stent is currently not on the market anymore, I think since 2017, but the Mark Myers is still very much going strong. But we have an abundance of options now. It seems like very much. So what do we choose? We're in the Cath Lab, we need to have the patient, what do we choose? So of course it always depends on what we are familiar with, what is available to us, and between different drug-eluting stents, there are so slight difference that it doesn't warrant recommendation of one over the other. But the main thing I want you to take away from this is that second generation, so current generation drug-eluting stents are the way to go. And even the bioresorbable scaffolds are not superior to the drug-eluting stents of the current generation yet. So we have chosen a stent, we put it in, and of course the stent comes with its own balloon to inflate it and sort of put it up inside the artery. And for that, we usually use high pressure techniques, so 12 to 16 atmosphere. And it's true that in this case, the higher the pressure, the better the stent will expand and position itself in the artery, and we have a lower risk of stent thrombosis, because the better the position is, the less there will be reactions with coagulation. So, but another sort of approach is to use lower pressure, because then we can avoid possible injury, and yeah, that's another approach. But mostly, never mind what we chose before. If we inflated with high pressure or low pressure, we would do a post dilation additionally with high pressure with an appropriately sized non-compliant balloon at like 12 to 16 atmosphere and achieve full stent expansion, because we need to make sure that thing's in there, and it has to be in there for, you know, a while. So then how do we know if what we did is adequate, that we served the patient well, and that everything's going to be fine for the patient? To sort of do that, we would measure the coronary pressure-derived myocardial fractional flow reserve. So the only thing you need to remember of this long thing is fractional flow reserve. And to do that, it's also during angiography, we measure the pressure. So first of all, we generate maximum hyperemic flow, either with adenosine injection or with a continuous intravenous infusion, and then measure the pressure once distally to the stented side, and then once in the aortic root, and compare these two. Normally, they should be the same. But if there's an 80 below, or even like if they're less than 80%, if the distal pressure is less than 80% of the aortic root pressure, then that means that in 90% of cases, that part of the myocardium can be provoked into ischemia. And this measurement is superior to just diagnosing visually whether the stent looks fine and the stenosis is gone on the angiogram. But still, a stent can fail. Why? There's two major causes of stent failure. One is stent thrombosis, which is life-threatening, of course, because it leads to ST elevation in a myocardial infarction in most cases. Can either happen early or late, that depends. We all know basically how it presents. It's the same as a myocardial infarction, just that, yeah, maybe it's our fault. And then there's in-stent restenosis, where, like I showed you in the OCT picture, we have gradual narrowing of the lumen inside the stent because the intima proliferates so much that there's sort of, again, an obstruction. And this will lead to stable angina and will mostly be caught in angiographic follow-up. So when there were still bare metal stents in use, this would happen in around 30% of cases, which is horrible. So now let's put this all into practice. We have a case with a 70-year-old man. 3 days ago, he received an elective percutaneous intervention into the right coronary artery. His previous medical history includes atrial fibrillation, and he also had an adenocarcinoma of the colon and metastasis in the liver. So these were removed, and as well, he received a hemicolectomy and had a colostomy formation 2 years ago. He had this elective approach, everything was uncomplicated. A drug-eluting stent was inserted in the proximal to mid right coronary artery, and they adequately post-dilated after stenting, like I explained, and there was no residual stenosis visually. Did they control that with the mechanisms I told you? Nah. They discharged him then, because of his previous AFib, on triple therapy with rivaroxaban, aspirin, and clopidogrel. This case is from 2019, and actually now you wouldn't do that. You would, upon discharge, discontinue the aspirin and send him home on just sort of dual therapy with rivaroxaban and clopidogrel. But I mean, they didn't know that this was inefficient. So yeah, we continue. So it's 3 days after the intervention. He returns to the hospital, has severe crushing chest pain. And I mean, we all know what that means, right? We auscultate, heart sounds are dual, there's no additional murmurs and the lungs are clear. And there's no elevation in jugular venous pressure and also no signs of heart failure. At least that's good. What do we see here? Does anyone want to say?
ST elevations.
Yes. What does that mean?
That means acute ischemia and damage to the myocardium.
What's the diagnosis we put?
Myocardial infarction with ST elevation.
Yes, and where?
We have ST elevations in V3, V4, V5. Yeah.
So the location is where? I'm not going to torture you, it's inferior. So again, it's in the same place where we stented. So some unimportant news for you now. He experienced cardiac arrest and was resuscitated successfully, but that's none of our concern. During this urgent coronary angiography that was performed, we see that the ostium of the right coronary artery here is occluded by a thrombus. And this is what we would classify under TIMI 0 flow. What's that? I will tell you. There's a grading system that grades quantitatively the amount of flow that passes through a coronary artery. So in 0, we have complete occlusion, as we see here. Then in N1, there's some penetration of the contrast media along the artery, but not distally. There's a lot of people writing in the chat. Does that concern me? Hope not. Oh no. But the contrast media does not really pass very much distally. Then in the second one, we have perfusion along the entire vessel of infarction, but the flow is delayed towards the distal bed. And then in the third one, we have full perfusion of the vessel, and the flow is completely normal. And from this, you would say both number 2 and number 3, these must be open arteries. But actually, in the case of number 2, we have significantly higher mortality. And even if we classify as 3, then it's still not with normal flow. You want to see the ECG again? I mean, you can, but this is not what we're aiming at right now. So tell me really quickly if you really, really want to, because we need to go somewhere else. Okay. And you can get the presentation afterwards and then look at it as much as you like. So since we still have this discrepancy between sort of open arteries, but then also not really, and mortality risks, this was optimized with the TMP classification. So here we have 3 grades where they assessed the perfusion of the myocardium, not just the flow through the artery. So we have 3 to 0 again, and in number 3, we see that there we have the ground glass appearance, where the contrast medium sort of flows through the myocardium, and it is gone at the end of the washout phase. And in grade 2, the dye does enter the myocardium, but it's more slow and at the end of the washout phase. So when everything should usually be gone, there's still some dye left. In grade 1, the stain does not leave the myocardium at all until the next injection. So there's a constant stain. And in grade 0, there's actually nothing of the contrast medium that really reaches the myocardium. So then he needed help. He received balloon dilatation and stenting. And now we see he has this is where the thrombus was, and we see very nice TME3 flow. Unfortunately, they didn't use the TMP scale in this case. But what they didn't do here is that they did neither OCT nor the EVUS to assess whether they adequately stented the artery. And they didn't do it the first time. They didn't do it now. So, you know, maybe this could have been avoided. So they only really controlled visually on the angiogram if the stenting went fine. What are risk factors for stent thrombosis? There's a lot. You can see them here. But the most important, and really, really the most important, is non-compliance to medical therapy, because you have your nice drug-eluting stent, a lot of development went into that, but then you don't take your dual antiplatelet therapy, and that completely screws you over. So, but this guy, nothing was said about non-compliance. And actually, this is a special case because remember, he has the colostomy, and since the absorptive capacities of the intestine correspond directly to its length, it's no wonder that he found the tablets fully intact in his colostomy bag some hours after ingestion, and that happened sort of from the second day after stent placement, which is why now he will receive the antiplatelet therapy crushed to guarantee that they are being absorbed and he doesn't have to come back for the same thing again. Any questions so far before we go to the next part? No?
I think we can move on. Thank you. It was really clear. Hello, everyone. So moving on to the radiofrequency ablation pathologies. So these are the pathologies for which we use radiofrequency ablation, and that includes atrioventricular reentrant tachycardia, AV nodal reentrant tachycardia, atrial tachycardia, atrial fibrillation, and atrial flutter. So not only AVRT and AVNRT have the similarities of not longing very last or rarely being life-threatening or producing symptoms like palpitations, shortness of breath, dizziness, and syncope. But there are some differences too. So in the AVNRT, the P wave might not be visible and the signal getting to the atria and the ventricles at almost the same time. So the P waves start essentially when the QRS starts. So when we add them together, the P wave gets sort of hidden or buried under the QRS complex. In the AVRT, the P wave might be seen or might not be seen depending on where the accessory pathway is located. Yeah, we can move on to the next slide. So the electrical signals, they use a separate accessory pathway to get back up from the ventricles to the atria, causing the atria to contract before the SA node sends the signal. So the signal then moves down the AV node to the ventricles and the Purkinje fibers, and then the ventricle contracts as well as goes up the accessory pathway, and then this sort of becomes into a cycle. So that is why it's called re-entrant. The clinical presentation of the patient is chest discomfort, palpitations, shortness of breath, lightheadedness, and in rare cases, the patient might also experience syncope. For diagnosis, we take an ECG for the patient. And we have two types of AVRTs. We have orthodromic and antidromic. For orthodromic, there is regular narrow complex tachycardia. P waves are typically retrograde in morphology, and they come after the QRS complex. The delta wave is not seen. In antidromic, there is a regular wide complex tachycardia, where the P waves are often not visible. So here is an ECG. So you can note that the QRS complexes are narrow and the absence of the P wave. And here is another ECG, orthodromic AVRT with regular narrow complex tachycardia with retrograde P waves. So you see them after, and they are visible after the QRS complexes, and mostly you can see them in leads 2, V4, and V6. And this is an antidromic AVRT ECG, and there is a regular wide complex tachycardia that is visually indistinguishable from VT, ventricular tachycardia. So the treatment, the medication for this, so if you want acute termination, you give adenosine or diltiazem, class 3. And for chronic prevention, you give amiodarone class 3 or prosenamide class 1A. The treatment options, other interventions. So for acute termination, you give vagal maneuver, electrical cardioversion if the pharmacological treatment is ineffective or the fast heart rate is poorly tolerated. And for chronic prevention, you do radiofrequency catheter ablation. Now, moving on to the AV nodal re-entry tachycardia pathophysiology. So just like the AVRT, it is a supraventricular tachycardia. But with AVNRT, it is in or near the AV node, which just like in the AVRT contracts the atria and the ventricle every time it goes around. So there are two separate electrical pathways that make up the loop, and one of the pathways has heart tissue that has slow electrical conduction, and this is known as the alpha pathway, and the other has fast conduction, and it's called the beta pathway. So the alpha pathway has a slow refractory period, which is the time it takes to be able to conduct another signal. And the beta pathway, on the other hand, has a long refractory period. So the signal comes down from the SA node in the right atrium. The signal goes down the fast pathway and reaches the other end before the slow pathway, and then splits to travel down to the ventricles, as well as up the alpha pathway where it meets the slow signal, and then they both cancel each other out. At the same time, both go under the refractory period, except the alpha pathway is shorter, so it comes out of refractory sooner and it is ready for another signal, while the beta pathway is still in refractory. So if another signal comes by, it will start down the slow pathway. But since the fast is still in the refractory, it will be blocked. So at some time, while the signals are still going down the alpha side, the beta side will come out of refractory and then it will be ready to go. So now when the signal exits out the alpha pathway to the ventricles and it enters the refractory period, it also travels up the beta pathway. And by the time it reaches the alpha pathway again, the pathway is out of refractory. So you have this re-entrant loop like a cycle, which sets up and which keeps going on and on every time around, and it causes both the atrial and the ventricular contraction, which again, like AV-RT, leads to high ventricular rates. So this particular setup, when it goes down the slow pathway or anterograde and up the fast pathway or retrograde, is called slow fast typical AV-RT. Then we have the fast, slow, or atypical AV-RT, which is less common. With this type, the pathway goes down the fast pathway or anterograde and up the slow pathway or retrograde. So the clinical presentation, the patient might have palpitations, anxiety, fainting or lightheadedness, chest pain, fatigue or weakness, confusion, which is most probably experienced by the elderly, neck pounding, neck and chest discomfort, dyspnea, and polyuria. So here is an ECG of the patient. And the risk factors, so alcohol consumption, anemia, anxiety, caffeine, chocolate, fever, hypothyroidism, hypokalemia, hypomagnesemia, hypoxia, myocardial ischemia, psychological stress, or stimulants. So treatment, vagal maneuvers. So you massage the carotid sinus or Valsalva maneuvers, which stimulates the vagal nerve, adenosine, beta blockers, or calcium channel blockers, which can suppress the AV and RT event by blocking or slowing the AV node. Other second-line therapies may include amiodarone or flecainide. For the calcium channel blockers, only of the verapamil type, not the nifedipine type of calcium channel blockers are used. Cardioversion is rarely used on patients with AV and RT, usually when the tachycardia is refractory to other medical therapies, or the tachycardia is causing hemodynamic instability like low blood pressure, heart failure development, etc. And the last option for treatment is radiofrequency catheter ablation. Atrial tachycardia is a form of supraventricular tachycardia which originates within the atria, but outside the sinus node, which is abnormal. So atrial flutter and multifocal atrial tachycardia are specific types of atrial tachycardia, and they are usually due to a single ectopic focus, and the underlying mechanism can involve re-entry, triggered activity, or increased automaticity of the heart. It may be paroxysmal or sustained, and multiple causes include digoxin toxicity, atrial scarring, catecholamine excess, congenital abnormalities may be idiopathic, and sustained atrial tachycardia may be rarely seen, and it can progress to tachycardia-induced cardiomyopathy. So the clinical presentation of the patient might experience palpitations, a fluttering in the chest, fainting, chest pain, shortness of breath, fatigue, or heart failure. Here are some ECG examples if you would like to see after. Yes, and the risk factors. So age, it is more prevalent in elderly patients, previous heart diseases, a stretched atrium, which results from high blood pressure, hypertension, or from cardiomyopathy, a previous heart attack, excessive use of alcohol, cocaine, and other stimulants is also a huge risk factor, and an irritable focus when cells outside the sinus node, they start generating an electrical impulse automatically on their own. So treatment options are catheter ablation and medications to control the heart rhythm, which include beta blockers, calcium channel blockers, or antiarrhythmic medications such as flavanid, propafenone, or amiodarone. Before we move on to atrial flutter and atrial fibrillation, which are two other pathologies for radiofrequency. So we will discuss the difference between the two. So in atrial flutter, the electrical impulses are organized, but in atrial fibrillation, the electrical impulses are chaotic and all over the place. Atrial fibrillation is more common than atrial flutter. In atrial flutter, we can see these sawtooth patterns on the ECG. In atrial fibrillation, the ECG test shows an irregular ventricular rate. The symptoms of atrial flutter tend to be less severe than the symptoms of atrial fibrillation. People with atrial flutter have a tendency to develop atrial fibrillation event after treatment, and ablation therapy is more successful in people with atrial flutter. So atrial fibrillation occurs when all the muscle fibers are contracting at different times. So the end result is the quivering or twitching movement. And in atrial fibrillation, signals move around the atria in a completely disorganized way that tends to override the sinus node. Instead of one big contraction, then there are some mini contractions that make it look like the atria is just quivering or twitching. So it is rapid, irregular heart rate, and the progression. So it is either paroxysmal, intermittent rhythm, may revert back to the sinus rhythm spontaneously, persistent 7 days more than, which requires intervention to convert back to sinus rhythm, and permanent long-standing atrial fibrillation and cardioversion is unsuccessful for such type of atrial fibrillation. Causes. So disorganized waves of atrial depolarization, exact mechanism of which is not well understood. Regular impulses of a sinus node, which are overwhelmed by rapid electrical discharges from various sources, automatic foci or multiple re-entry phenomena, and it arises from the left more than the right atrium. So the signs and symptoms, it may be asymptomatic, dyspnea, fatigue, palpitations, lightheadedness, weakness, chest pain, and hemodynamic shock. So in the ECG, you can not find P waves, irregularly timed QRS complexes. So you have the irregular RR intervals, and no sawtooth waves are seen in atrial fibrillation. So here you can see in V1, atrial fibrillation. Medications, so anticoagulants, and for rate control, you use beta blockers, preferably beta-1 selective, non-dehydropyridine calcium channel blockers like diltiazem or verapamil, digoxin. Chemical cardioversion can be performed, which administers the antiarrhythmic medication class 1C, class 3 antiarrhythmics, and for the maintenance of sinus rhythm after cardioversion, you use class 1C and class 3 antiarrhythmics. Other interventions, so for rhythm control, for restoring the sinus rhythm, cardioversion, you also perform electrical cardioversion. And another option is catheter ablation, which is destruction of heart regions which are responsible for abnormal impulses. So now moving on to atrial flutter. When the atria contracts in high rates above 300 beats per minute, it can be 300, 400. So why flutter? There is a wave of muscle contraction that flows through the atria that looks like as if it is flapping or fluttering, hence the name flutter. And in atrial flutter, a re-entrant rhythm starts either in the right or the left atrium. So re-entrant signals, they loop back in themselves, overriding the sinus node and setting up an endless cycle that causes the atria to contract again and again, really at really fast rates. So we have two types of atrial flutters. Yes, thank you. Or typical atrial flutter. So it is more common and is caused by single re-entrant circuit that moves around the annulus or the ring of the tricuspid valve of the right atrium, and usually in the counterclockwise direction when viewed up through the tricuspid valve. So you can see in a like an eagle view. So you can see the superior vena cava and the inferior vena cava and the coronary sinus. So in this case, a stretch of tissue along the pathway called the cavo-tricuspid isthmus. It propagates the signal more slowly than the surrounding tissue. So the tissue that was just activated can't be activated again until a certain amount of time is passed, which is called the refractory period. So that is slow propagation through the isthmus gives the tissue enough time to be out of refractory, and therefore the circuit can loop back on itself. The type 2 or the atypical atrial flutter is where the re-entrant circuit develops either in the left or the right atrium, but the exact location is less clearly defined. A wave of activated tissue or depolarization hits the tissue in such a way that it creates a loop of depolarization that keeps going around and around. So here is how the ECG looks like and how to evaluate it. Yeah, 3:4, 2:4. So I just put some two different pictures so if you want to see. Yeah, and so here is an ECG of a patient, and this is an example of anti-clockwise flutter. So inverted flutter waves in 2, 3, and AVF at a rate of 300 beats per minute, 1 per big square. You can see upright flutter waves in V1, which is stimulating the P waves, a 2:1 AV block resulting in a ventricular rate of 150 beats per minute. And you can also notice the irregularity with a 3:1 cycle, which is seen in V1 and V3. So the signs and symptoms, shortness of breath, chest pain, dizziness, nausea, prolonged tachycardia. And then it leads to ventricular decompensation, and further it leads to heart failure or atria not contracting effectively. So the blood stagnates and it forms blood clots, and then it embolizes to the brain, and then it further leads to stroke. So for treatment, we use anticoagulants to reduce the clot formation, beta blockers, calcium channel blockers to control the heart rate, cardioversion, and radiofrequency catheter ablation. Now moving on to the Wpw syndrome. So existence of an alternative electrical pathway which directly connects the atria and the ventricles bypassing the AV node. So in this syndrome, there is a muscular bridge between the atrium and the ventricular, which acts as an accessory pathway. A small percentage of all cases are caused by mutations in the PRKAG2 gene, which is a genetic cause. And the delta wave can be seen because there is an accessory pathway. So the conduction capacity of the accessory pathway does not necessarily cause tachycardia. If it does not cause tachycardia, then it is asymptomatic. For this, we could not give antiarrhythmics or perform ablation for this type. Yes, so pathophysiology, as we discussed before, so this is a congenital accessory pathway which is formed between the atria and the ventricles, which leads to pre-excitation, and it predisposes individuals to clinically significant arrhythmias up to a sudden cardiac death. So through the bundle of Kent. So it is a common eponym for congenital accessory pathways. Several different pathways can occur, most commonly direct atrioventricular connections, but also atriofascicular and atriohisian, which are another types. Wolff-Parkinson-White syndrome is benign, asymptomatic form, solely described by compatible electrographic changes, and most common type of ventricular pre-excitation syndrome. and 0.1% of individuals have Wolff-Parkinson-White syndrome, and a small proportion of them develops the syndrome. So there, you might be knowing that there is Wolff-Parkinson-White phenomenon and Wolff-Parkinson-White syndrome. The signs and symptoms of the patient is tachyarrhythmia, palpitations, chest discomfort, breath shortness, lightheadedness, dizziness, or syncope, which is quite rare. So the clinical features and the examinations. So on auscultation sound, you hear reverse splitting of the second heart sound, early pulmonic closure, and early activation of the right ventricle. So what are some likely diagnoses you can think of based on the given information? So you can perform electrocardiogram, where you can see short PR intervals and the time for conduction between the atria and the ventricles, and delta wave, which is the early conduction to the ventricles through the accessory pathway. So the delta waves show you the pre-excitation, and the short PR interval shows you that there was less time for conduction between the atria and the ventricles. And you can also perform electrophysiological testing to determine the reason for the tachycardia, and you can identify the location of the accessory pathway and determine whether the accessory pathway was dangerous or life-threatening for the patient. So for the diagnostics, you can find short PR interval and delta waves. You can find slurred upstrokes of QRS, widening of the QRS complex, and secondary ST segment or T wave changes. So these are some common characteristics of Wolff-Parkinson-White in an ECG. And here we can see an ECG of an individual with Wolff-Parkinson-White syndrome in sinus rhythm, and the delta waves are mostly visible in V leads. And here is another ECG demonstrating pre-excited AFib or atrial fibrillation in a person with Wolff-Parkinson-White. So it's an irregular white complex rhythm with no P waves. And for the prognosis, it has excellent prognosis. So some patients with Wolff-Parkinson-White syndrome may be at increased risk for cardiac arrest or sudden cardiac death due to the family history, complicated accessory electrical pathways in the heart, and severe tachycardia symptoms. However, even for those at an increased risk, there is availability of treatments that can permanently stop the symptoms of the syndrome, such as radiofrequency catheter ablation. So for the treatment, medications, so for acute termination, you can give adenosine L-diazepam class 3, and for chronic prevention, you can give amiodarone class 3 and prosenamide class 1A. And other interventions, so for acute termination, you can give vagal maneuvers, electrical cardioversion if the pharmacological treatment is ineffective or fast heart rate is poorly tolerated. And for chronic prevention, you can do radiofrequency catheter ablation, which Sophia will tell us after.
Hi, I'm back. Luckily, Samisha just did a complete roundup of several semesters of cardiology, but you don't necessarily need to remember everything she said for what I'm about to tell you, because I guess maybe we lost some of you. What do we know about radiofrequency catheter ablation? What we all know is that there's a catheter placed in the heart, and then in some mysterious way, we find where there is abnormal conduction of any kind, and then we destroy this place of conduction so it can't happen again. This is enough to go through medical school, but not for us. We are going deeper. Radiofrequency catheter ablation is always performed as a part of invasive intracardiac electrophysiological study. This is another word, a big one. During this, we analyzed in detail what mechanism underlies the arrhythmia, locate where the site of origin is, precisely where it comes from, and then we can also apply treatment if and when necessary. In preparation for that, we need to discontinue or taper, depending on the medication, pretty much everything that interferes with conduction and heart rate, because we want to experience the heart in its diseased self, sort of. And then we either sedate the patients or apply general anesthesia, depending on how long the procedure is going to take. So for surveillance, we put on the standard 12-lead ECG, also hands-free defibrillation pads if at some point we have a shockable rhythm that we need to shock. We need to be prepared for that. And we monitor arterial blood pressure and oxygen saturation. Again, how do we know where we are? What's going on? We can use fluoroscopy like during angiography, but also some experienced electrophysiologists, and now it sounds like magic, but it's true, can actually do it without any sort of visual guidance, but they just measure around the currents in the heart and they know where they are. So people tell you magic doesn't exist, it does. We can use multiple venous vascular access points, and pay attention, it's venous. Last time we were arterial, now we're going in by the veins. So we can, most commonly we would use the femoralis, but we can also use the subclavia, the internal jugular or the brachial vein. And actually we can freely combine among the selection. Here you can see in the picture where we place these multiple electrodes to analyze how the conduction travels through the heart. So there's one in the high right atrium. Let me just show you, it's here. Then one near the anterior tricuspid valve annulus to measure the His bundle. Then one in the right ventricular apex and one in the coronary sinus. This is all in the right heart, so still in the venous circulation, but if necessary, we can also enter the left heart either by puncturing the septum or by going in retrograde by the aorta. And we will need that later, because if I'm not losing you now, there's a strong chance I will later, but I'm trying my best. You can understand this, it's possible. So what does the electrophysiologist see when he's measuring? She, maybe. We have the simultaneous recordings of the intracardiac and the conventional ECG. So we have several leads. For example, this one is one from the high right atrium. These are the conventional leads. Then this is from where the His bundle is. Then we have some in the coronary sinus, and here is one from the apex. This, to me, sounds like a foreign language. I guess it will to you too. But also, again, you don't need this to follow me along for this ride. We record several things. Ideally, we start recording in the high right atrium close to the sinus node and evaluate the function of the SA node. So for that, we have two parameters. First, the sinus node recovery time, that reflects the automaticity of the node. And then we have the sinoatrial conduction time that reflects the conduction properties around the sinus node. And then we can also evaluate the AV conduction. So we see if we additionally stimulate in the atrium, if we can cause tachyarrhythmia. Then we measure again near the His bundle to evaluate that. Then we make some few recordings from the coronary sinus to see what, sort of look into what the left heart does. And then we also measure at the apex in the right heart to see if we stimulate there, we can we see what happens basically. And then there's some additional recordings you can make, but we're not going to talk about that because then I'm really going to lose you. So the interesting part in the electrophysiological study, where you move forward to the ablation process, is when you start mapping, because you want to know the exact location where there are potentials, maybe rotating in the atrium that lead to atrial fibrillation, or maybe there's an accessory pathway that causes tachycardia. So we need to really map out the space to see where and when in the cardiac cycle electricity is moving through the heart in whatever approximate location of interest we're looking at. So for example, the right atrium. And there's several techniques. You can do this just with these sort of intracardiac ECGs like I showed you, but there's a lot. I listed some here. If you go into detail for that, you can become an electrophysiologist, but you will also lose yourself in the process. I mean, at this stage of knowledge, I would say. But yeah, we do the mapping, and we do the mapping only if we know that the arrhythmia has a known anatomic cause. If it doesn't, then there's no use in mapping because there's nothing specific we are intending to find. So don't do it just because it's fun, you know. Mapping. So again, here, similar to what I showed you before, we have different locations in the coronary sinus where there have been measurements taken, a location from the right ventricular apex, the his bundle, high right atrium, and the conventional leads. So in this case, I mean, you could see that here we have type 1 atrial flutter. But for this, ablation is done really just anatomically. We draw a line between the tricuspid annulus and the inferior vena cava to sort of block this conduction in two directions, and then everything's fine. But in other cases, we can use sort of more visually interesting mapping. So this computer game-like thingy we have here. And that's actually when we have a special catheter with a locatable sensor that is sort of moved around in the heart and has a navigation system. And this then digitally creates this map of where the impulse moves through the right atrium. You can see here sort of how the different voltages would then look. And then we can really see ectopic activity in all its colorful beauty. And this strategy is extremely useful when we at some point maybe have to do electrophysiological study again, because then we can really compare how was it today, how is it in 2 years, because that of course can be important to have something to go back on. So more really nice pictures here. The results of the mapping were actually fused with priorly taken 3D CT and MRI. So this 3D image of the heart was generated, and the mapping results were put on top, and we can see really nicely how this travels. I completely understand if this looks to you like a funky cardiac map. It's fine. You don't need to further get into this. It's just to show you what's possible, because I think this is amazing. So then I'm going to show you a video real quick. It's this one. And here we have a patient who actually previously had an infarction. And we see on the left side that the myocardium is actually not has not the same thickness all throughout, and they wanted to see how that would affect conduction. So they did the mapping and then also put it on top of a model, and you can see how the impulses travel. So, I mean, this is very extensive, but you're looking at the future here, and it's really nice to see. So then this one last thing to sort of illustrate. Here they did some imaging to assist with ventricular tachycardia ablation in a case of myocarditis. So in picture A, we can see here, we have scarring on the left ventricle. And then in picture B, they again combined MRI and 3D CT to generate a really nice model of the heart. And then here in C, they put on top of their model these imaging, so the voltage map, so to say, of what they did during the mapping. And here then you can see angiographically, this is the ablation catheter. Here's an electrode. And now they're going to ablate near the artery. And ablation was actually performed sort of exactly here where we see the blue dot. And this is what the electrophysiologist also saw the whole time during the procedure. So let's go back a bit, step away from the maybe a little bit too crazy stuff. For radiofrequency ablation or this whole ablation procedure, we can use different energy sources. There's DC energy, and this is basically just historical. This is what they first tried out. And actually there's such a high energy discharge that basically the risk of complications is so high, and the actual amount of complications is so high that it was not really a thing to be done. But what is mainly used now is radio frequency energy. So we have low voltage and high frequencies so we can achieve really in a really small spot controlled focal tissue ablation. And because this does get hot, because we're essentially burning something away, we need to immediately irrigate with saline to cool the catheter tip, because if there's just some hot piece lying around in the heart, then we could have coagulation and pulmonary embolism, death, you know, the whole thing, not good. So then there's another approach, another type of energy, and that's cryothermal energy. And this is actually really genius. So they don't use heat, but rather the absence of it, where they, so you find the place where, via mapping, where your abnormality in conduction is, and you want to remove it. So you think you found it, and you place your catheter tip there, and you cool this exact area down a bit and look at the ECG, the whole amount of different leads you're receiving, and you see, does it go away, or is it maybe still there? And if it does go away, you can then freeze it really profoundly. So then there's permanent damage, and you have, like in conventional radiofrequency energy, achieved sort of removal of the arrhythmia. But if you are actually at the wrong point, you haven't unnecessarily permanently damaged the myocardium, because if you just cool this area and you find that this is not the right area to help you with curing the arrhythmia, then you can still say, hey, we're going to try another place, and the area you tried out will just warm up to normal body temperature again, and there's no loss of function. So pretty genius, if you ask me. And now we're going to put this to good use for a really nice case. This one takes place in Japan. There's a 15-year-old boy, he's 15 now. But when he was in first grade, actually the Japanese, they do some really nice stuff, because they do ECGs routinely on every school child in different grades. So they have their hidden arrhythmias and heart diseases, they have them in check. And he received an abnormal one in first grade where they found a delta wave. And you all know what that means, right? So now he's 15, he's been asymptomatic the whole time, regularly follows the outpatient sessions, his chest x-ray is normal, echo as well. They put him on Holter EG a couple of times and got his heart rate up to 204 beats per minute, but the delta rhythm didn't disappear. And then 3 months ago, everything changed because he had palpitations suddenly out of nowhere for 3 minutes. Here we can see his ECG. Again, very nicely, we see the isoelectric delta wave here, and then negative delta waves in 2 3, and AVF. They're very steep, so yeah, that's what we have. And then we have an X-ray, a new one, at 15 years of age. Does anyone see anything? Not a serious question, me neither, it's normal. Yeah, so the chest X-ray is normal. They did an echo again, it was normal, and please remember that, because it will be important later. And then another Holter ECG, and during sinus tachycardia, he had a maximum heart rate of 188 beats per minute. On the treadmill exercise test, they also got his heart rate up really high, but the delta rhythm was still there, and he didn't have any atrial fibrillation or paroxysmal supraventricular tachycardia. And then they made the decision that this was PSVT, and thus there's a necessity for radiofrequency ablation, but of course, never without electrophysiological study. He's a little boy, we don't want to torture him unnecessarily, so general anesthesia, and we insert a 5F sheath. We're gonna do a quick recap here. What does the F stand for? It's the French, and it's the diameter of the catheter lumen. And does anybody know why it's called French?
Because the Americans were too lazy to pronounce Charrier, but it's the same thing as Charrier.
Very nice. We have some intelligent people here. I hope you all listened. So we have inserted this 5F sheath into the vena basilica dextra, and through that put a 5F electrode into the coronary sinus. And then another 8 and 5 French sheath was inserted into the femoralis. And via that, 2 French electrodes were put into the high right atrium, his bundle, and right ventricular apex. All pretty standard up till now. I hope I haven't lost you. So what they did first was ventricular pacing. So they stimulate in the ventricle and measure in the atrium. And then the earliest activation is seen in the coronary sinus and very proximally, so only 5 to 6, the numbers can go further up. Then they did the reverse thing and stimulated in the atrium. And then they see that they could provoke narrow QRS tachycardia, while the His bundle was in a refractory period. So that means there has to be an antegrade accessory pathway with a very short effective refractory period. So they made a diagnosis, it's orthodromic, and an atrioventricular reciprocating tachycardia by the left posterior accessory pathway. So they assume the accessory pathway on the left, which in turn means we have to cross to the arterial circulation. So they puncture transeptally and sort of put everything they have brought into the heart over to the other side and look at everything from the other side in there, because they suspect they have found the approximate region where the accessory pathway must be. They start mapping with this 4mm tip ablation catheter, and they do that during sinus rhythm around the mitral valve annulus. And at the earliest ventricular activation, they ablate, but they still have the pre-excitation. So this must have been wrong. And had they used the cryo energy, maybe they wouldn't have destroyed the little bit of his heart, but the boy's fine, spoiler alert. So they need to think of some other location where the pathway might be. So it could be either epicardially or on the right post-receptally. So they go back into the venous circulation and further map the currents there. And then they see that there is the typical fusion of conduction of the atrium and ventricle with potential for an accessory pathway in the coronary vein, about 10 millimeters distally from the coronary sinus ostium. There they finally ablate, and then within 2.4 seconds of ablation at the specific temperature and ohm and everything, the delta wave disappeared. They were successful. To then sort of make sure everything is really, really fine, they did some more ventricular pacing, but there was no more ventricular atrial conduction. And also during further electrophysiological studies, everything was fine. This is the ECG afterwards. Not a lot to discuss about this. Everything looks really nice. And since they found a pathway posteriorly, they need to, so actually the angiography is now indicated. And since they are already in there, they can, it's the same as in the Cath Lab again. So they can just quickly perform angiography in the same session, so to say. And here I can explain again. Here there's one electrode in the high right atrium. There's the coronary sinus, the His bundle, the right ventricular apex. This is just the view we are currently in, and this is the ablation side. And actually the ablation side is just in the neck of what they find is a coronary sinus diverticulum. And they finish the procedure, take their patient back to the department, and then later perform an echo again, which they have done several times before, and it was always normal. And here we can see now a very sizable coronary sinus diverticulum, once in the long section and one in the cross section here. So, and then they also did a 3D CT, both of which, the 3D CT and the echo, they could have found this in earlier, where again we can see this huge sinus diverticulum. And what I actually pretty much want you to take away is that in pediatric patients with Parkinson-White syndrome, we need to check for the coronary sinus diverticulum, as it is a frequent cause for these patients, that the accessory pathway is located near there. And we need to do that before we start electrophysiological study, and before the mapping also we should already do the angiography, because then we can be more safe. We could have avoided having this one ablation site in the left atrium that was just unnecessary, because everything can lead to complications. You know, he could not be here today, basically. So just take away that. It's a very niche piece of info, but there you go. Thank you for your attention. Do you have any questions?
Yes, what does this diverticulum has to do with the location of the bundle of Kent? Why is it associated with one another?
Yes, that's a good question. So you see here, we have the atria and the ventricles, and normally, like Semishta said, there's a muscle bridge between atrium and ventricle that causes with Parkinson-White. But if there is sort of this big diverticulum, this can be the point where the currents cross from one place to the other. That makes it clear.
Okay, so the mass of the diverticulum allows the crossing of the current.
Yes, because this is the bridge then.
Thank you.
Anyone else?
I have some questions, well, but it's not just about this last part, but also that I just wrote since the beginning of the presentation.
Okay.
Okay, so when we talked about the arterial aneurysm, so they mentioned that if there was some syndromes like Marfan syndrome and stuff, that we start this treatment earlier. So what does that mean? Does that mean that we do the invasive treatment in case there's less than 5.5 centimeters? Or does that mean that we do some prophylactic medication?
We cannot do anything with medication. So the only treatment option is then the invasive placement of this graft in the aorta. So we would then, in an earlier stage when the aneurysm would be still smaller, would then set this stent there.
Okay, so it's just us to do that. Also, you also mentioned that like there's no symptoms. So in case there's a high risk patient, how can we prevent it? Do we do just more tests, more investigations, or like what is the strategy?
And we can monitor it. So we can easily monitor it with an ultrasound. So as I mentioned, you can just point an ultrasound at it and you can see it. You can see the size, and then you can monitor over a longer period of time if it grows. So then we can make the decision, okay, now we have to put in the graft to prevent a possible rupture.
Okay.
One of the preventions, what is indeed important is to keep the blood pressure within normal limits, because I remember also from hypertension emergencies that if hypertension emergency is linked to aortic dissection, that was one of the rare exceptions where we lowering blood pressure drastically. Yeah, just in one moment to 110 or 100. So in those patients with aortic aneurysm, we pay indeed very close. We put our eye to their blood pressure, and you know that normal values today are somewhere between 120 to 130 if you treat hypertension in persons who are below 65 years of age. So in those patients, you definitely want to be closer to 120, 110. That would be one option. And the other thing, yes, as Leo said, ultrasound, but also don't forget, guys, when you want to get indeed precise information in 2021 about coronary arteries or aortic sizing, or so, remember investigation, which was mentioned here, CT angiography. Yeah, so that's the state of the art to detect the size, because ultrasound is very good but not absolutely precise. Thanks.
Thank you. And just one more question about the stents implantation. How big is the possibility of reocclusion or after placing a stent, or restenosis, etc.? Like, is
that depends on the stent you use. So as I said, with the bare metal stent, where was this? I don't remember where it was, but with the bare metal stent, there's actually a 30% chance of reocclusion. And 30% it did reocclude. And then of course it's significantly lower for the drug-eluting stents. I can send you some sources if you want exact numbers, if that helps you.
Yeah, so actually just what Sophia said, just because of what Sophia said, we do not use any more bare metal stents.
Exactly.
Right? Because that would be pretty much not the best treatment for our patients, because indeed it's 35%, right? Especially for patients with diabetes. So instead, right now we use drug-eluting stents, and what Sophia showed, those third generation stents, their restenosis rate is somewhere between 0 to 3, 4, 5%. Yeah. So, and I would advise you to speak about two processes regarding stents: restenosis or stent thrombose. Because when you say reocclusion, it doesn't make clear what's going on exactly. Most of the time we speak about restenosis, which would be more chronic process. But then we can have also what Sophia nicely showed, this classification, also the reasons for stent thrombose. Mm-hmm. Thanks.
Good question. These percentages you just mentioned, are these per annum or lifetime?
You see, then I will ask you, it's not a good style to answer a question with contra question, but may I ask you, I'm sorry, I don't see you. Is it not a good idea to put your camera on, or you're
Give me a second.
You're discreet? No, I mean, guys, it's like kind of, we got some Zoom etiquette while using this application. So I believe, may I ask you, what do you think? If we would put a stent, as Sophia showed, if person developed stent narrowing 2.5 or 3 years after stent implantation, should we call it restenosis, or is it already some new plaque and progressive disease? And this is tricky to answer, you see, because what we know, when we place the stent, then you have the higher risk of restenosis during first 6 to 12 months. And if like those percentages coming mainly from 12 months follow-up after the stent, this percentage. But because if you say, okay, let's look on 5-year results, we do trials following longer time, of course, but then it's a little bit difficult to answer because the stent did his job. Basically, he stayed there to open the vessel, release the drug, to protect smooth muscle growth, and etc. So, and it's possible, and we tend not to call it restenosis if it's happening like 3 or more years after stent implantation. But it's still debatable, and it's specifically, you imagine, it will be specifically interesting question, as Sophia showed those scaffold idea. Yeah, so imagine if you put scaffold. So you put in scaffold, and within 12 months, there is nothing there. Okay, so and then what? If person, for example, starts to smoke or do not control risk factors, yeah. So will we blame 2 years after scaffold implantation? What are we gonna blame? Whether we blame scaffold because of progressive disease, or we would look more closely on patient's profile. Yeah, so it's tricky here.
Okay,
Thanks.
thank you for the answer.
Do we have more questions? I would actually say maybe we continue because it's already 6:45. Okay. Then for Professor Trzynski, would you like to do